Hello, my name is Jessie Ortwine, and I am an infectious diseases clinical pharmacy specialist at Parkland Hospital in Dallas, Texas. Today, I will be reviewing pertinent drug information for monoclonal antibodies as it relates to the treatment and prophylaxis of SARS-CoV-2. Naturally occurring antibodies against SARS-CoV-2 are produced by the adaptive immune system within a few weeks of exposure to the SARS-CoV-2 virus. The degree of antibody production appears to correlate with severity of illness, but the duration of antibody memory remains unknown. The process of antibody-mediated viral neutralization can be sped up by directly administering antibodies to patients in the form of convalescent plasma or monoclonal antibody therapy. This is known as passive immunity. In contrast to convalescent plasma, monoclonal antibody therapies for COVID-19 contain known quantities of one or two specific antibodies that are known to target designated binding sites on the virus that correlate with viral neutralization activity. Additionally, these therapies are able to be mass-produced without the need for convalescent donors. In general, monoclonal antibodies act in a number of ways to assist with infection prevention and treatment. Against the SARS-CoV-2 virus, antibodies work by preventing the virus from engaging with the host cell binding site, a process known as viral neutralization. In addition, antibody binding to SARS-CoV-2 also assists with recruitment of immune system effector cells to help clear the pathogen. If you are interested in learning more about the antibody functions in infectious diseases, I highly recommend the article referenced on this slide. Most monoclonal antibodies in development against SARS-CoV-2 are designed to bind to the spike protein. This protein has two functional subunits, S1, which is responsible for viral binding to the ACE2 receptor, and S2, which is responsible for virus cell membrane fusion. Within the S1 subunit, there are two domains, the N-terminal domain, or NTD, and the receptor binding domain, or RBD. The receptor binding domain is the primary target for the monoclonal antibodies currently in development. Monoclonal antibody binding to this domain blocks viral entry into cells. As such, the current hope is that monoclonal antibodies will be able to be used both as prophylaxis for high-risk persons as well as for treatment. There are currently 4 monoclonal antibodies that have sufficient information to discuss in this presentation. 2 of the antibodies are being developed by Eli Lilly and are being studied both independently and in combination. The other 2 antibodies are being developed in combination only by Regeneron. The first monoclonal antibody we're going to review is Eli Lilly's LICOV555, more recently referred to as bamlanivimab. Serum from a convalescent COVID-19 patient served as the origin of over 400 potential antibodies. These were narrowed down based on desirable qualities, including ability to bind to the spike protein, degree of neutralizing activity, receptor binding domain epitope or binding site competition, and ACE2 blocking activity. A few antibody finalists meeting all of these criteria emerged. However, despite similar RBD binding, ACE2 blocking and binding affinities, LICOV555 showed substantially greater neutralization potency compared to the other finalists, as shown in the figures on the right side of the slide against 2 different viral isolates. The study's authors suggest that this may be due to the ability of LICOV555 to bind to its epitope not only when the receptor binding domain is in the ACE2 receptor accessible or up configuration, but also in the down configuration when the RBD is shielded from ACE2 receptor binding. LICOV555 has been studied as prophylaxis against SARS-CoV-2 in Rhesus macaques. In this model, 3 to 4 animals per group were dosed with 1, 2.5, 15 or 50 milligrams per kilogram of antibody or 50 milligrams per kilogram of a control antibody and were subsequently inoculated with virus 24 hours later. Changes in viral load were assessed via BAL fluid, nasal swabs, and throat swabs collected on days 1, 3, and 6. Viral load was described in terms of genomic RNA and subgenomic RNA. Genomic RNA represents virus present in both the initial inoculum as well as a newly replicating virus, whereas subgenomic RNA was specific to newly replicating virus. Changes in viral load over the 6 days post-inoculation are shown in the figures on the right. Mean genomic and subgenomic viral concentrations were lower in all BAL and nasal swab samples on day 1 compared to the control group. Viral replication in BAL samples, as well as among all nasal swab samples except in the lowest dose group, were undetectable by day 3. In addition, lung tissue obtained via necropsy on day 6 revealed no evidence of viral replication in the 2.5, 15, and 50 mg/kg antibody-treated animals. Multiple clinical trials of LiCoV-555 have been initiated, with the most pertinent ones listed here. This antibody is being studied alone and in combination with another Eli Lilly antibody product in a variety of settings, including as treatment in inpatient and ambulatory settings and as prophylaxis for residents and staff of skilled nursing homes and assisted living facilities. Results are currently available for parts of BLAZE 1 and ACTIVE 3. Now we're going to shift into the available clinical data for bamlanivimab in humans. The BLAZE 1 trial is an ongoing phase 2 trial assessing the effect of bamlanivimab on non-hospitalized adult patients reporting at least one symptom of mild to moderate disease, including fever, cough, sore throat, malaise, headache, muscle pain, GI symptoms, or shortness of breath with exertion. Subjects also have to have had their first positive test result within 72 hours of receiving the antibody infusion. The full BLAZE 1 trial is made up of 3 different study groups. Part A is studying bamlanivimab monotherapy at 3 different doses compared to placebo, and data from this arm was recently published in the New England Journal of Medicine. Part B is studying combination therapy with bamlanivimab and another Eli Lilly antibody, LiCoV-016, also known as etesevimab. And Part C is looking at this same combination therapy as Part B, but solely in patients at high risk for COVID-19 complications. All 3 parts of the study have identical outcomes, with the primary outcome being change in viral load at day 11 post-positive test. Interim results from the bamlanivimab monotherapy portion of BLAZE 1 have been published. This interim analysis was pre-planned and occurred once the final patient randomized to receive bamlanivimab reached day 11. Baseline patient characteristics are shown here. There were just over 100 patients in each of the 3 treatment arms. The authors described that the 700 milligram dose was projected to be the maximally efficacious therapeutic dose. However, they chose to study up to a 10-fold higher dose to ensure adequate coverage, as well as continue to establish the safety and tolerability profile of the antibody. The placebo group in this publication is documented as including 143 patients, but in the EUA fact sheet there are 156 patients reported to have received placebo. Importantly, about 70% of patients in both the treatment and placebo groups were noted to have at least one risk factor for severe disease. Risk factors were defined as age of 65 years or greater, body mass index of at least 35, or one of any pre-specified coexisting illnesses which were not defined in the available study protocol. The majority of patients had mild disease with 4 days of symptoms prior to study enrollment. The baseline viral load was described in terms of cycle threshold, and this value was about 24 in both groups, and per the authors, approximated a viral load of 2.5 million RNA equivalents. The primary outcome of mean log change in viral load among patients receiving placebo was a decrease of 3.47. Patients in all of the treatment arms showed similar decrease in viral load at day 11, regardless of dose administered. Interestingly, only the 2,800 milligram dose showed a significantly greater decrease in viral load compared to placebo. However, there's no good explanation for why this occurred in the intermediate dose group only, and is potentially due to random chance. So essentially, all doses performed equally by day 11. In fact, you'll notice when looking at the EUA that the 700 milligram dose was ultimately the dose approved. Secondary outcomes included an analysis of viral load decreases at earlier time points. A significant difference in viral load change from baseline compared to placebo was observed in the pooled treatment group as early as day 3, but by day 5, viral load changes were similar to placebo, suggesting a possible early benefit in therapy. An additional secondary outcome was the rate of hospitalizations, ED visits, and death. Despite being significantly different event types, hospital admissions and ED visits were described as a combined endpoint. A total of 5 incidents occurred among all patients receiving bamlanivimab compared to 9 receiving placebo. No deaths occurred in the study. A post hoc analysis performed among patients 65 and older or with a BMI of at least 35 revealed a hospitalization rate of 15% among patients randomized to the placebo group compared to only 4% in patients receiving antibody therapy. Importantly, this post-hoc analysis included just under 150 patients considered high risk, but based on the baseline characteristics presented, 310 patients were high risk. Additionally, the number of patients at risk for hospitalization presented on the EUA fact sheet is a total of 205. The details regarding the definition of the 3 different high-risk groups are not specified, so it's really unknown how to apply this information to determine who may benefit most when evaluating patients. Looking at symptom scores, patients assessed their own symptoms daily, ranking the severity of 8 symptoms on a scale of 0 to 3. Improvement in symptom scores from baseline was evident in the pooled treatment group by day 2. This improvement from baseline among patients receiving LiCoV555 compared to placebo was observed through day 6. Per the EUA fact sheet, the median time to symptom improvement was 6 days for patients receiving therapy and 8 days for placebo. All doses of the antibody therapy were well tolerated, with no major differences observed in the rates of adverse events of any severity between any of the treatment groups and the placebo group. Adverse events occurred in 22% of patients receiving the study antibody and 25% of patients in the placebo group. The most common adverse events noted in the bamlanivimab groups were nausea, diarrhea, and dizziness, all which occurred at rates of less than 4% among all pooled doses. The rates of these and all other adverse events occurred at similar frequency in the placebo group as well. Infusion-related reactions, which included pruritus, flushing, rash, and facial swelling, occurred in 2.3% of patients receiving LiCoV555 and 1.4% of patients receiving placebo. The authors noted that vital signs remained stable during these infusion reactions, and all patients were able to complete their infusions despite experiencing these adverse events. The ACTIV-3 trial is the first trial within the Therapeutics for Inpatients with COVID-19, or TICO, platform established by the National Institutes of Health. The TICO platform is set up as an adaptive platform to study multiple agents for the treatment of COVID-19 in hospitalized patients experiencing symptoms for 12 days or less. Inclusion criteria are listed in the left-hand column. Patients were randomized to receive a single dose of 7,000 milligrams of LiCoV555 or placebo. The primary efficacy outcome was sustained recovery during 90 days of follow-up, with a key secondary outcome focusing on all-cause mortality. A futility assessment was also performed on day 5 that evaluated pulmonary and extrapulmonary disease manifestations in the first 300 enrolled patients. The purpose of the futility assessment was to determine if the experimental therapy was beneficial enough for the study to continue into the second phase, which would enroll 700 additional patients. This assessment evaluated 2 outcomes on day 5 using 7-category ordinal scales. The 7 categories for the 2 ordinal outcomes are shown here, with the definitions for each category indicating an increase in disease severity as the categories move from 1 to 7. Baseline characteristics of patients in the treatment and placebo arms are shown here. Just under half were either Hispanic or Black, and the majority were obese. Participants experienced about 7 days of symptoms prior to randomization, and most had either no oxygen requirement or needed less than 4 liters per minute of low-flow oxygen at the time of randomization. The majority of patients in the trial received concomitant remdesivir starting either before or on the day of randomization. Roughly half of the patients in each group also were receiving steroids at the time of randomization. The results of the futility analysis are shown here. On day 5, the proportion of patients in each of the different disease categories was nearly identical. The data shown here are for the pulmonary ordinal outcome. However, the authors note that the results of the pulmonary plus ordinal outcome were nearly identical to those results shown here, with the exception of 2 patients who ended up in more severe categories in the pulmonary plus ranking than they were categorized as in the pulmonary ranking. When the pulmonary ordinal outcome data was stratified by patients' baseline pulmonary category, there was no category of patient that had any perceived benefit from antibody therapy at day 5 compared to placebo. In addition to the futility analysis resulting in nearly identical outcomes in both the treatment and placebo groups, results of the primary clinical outcome of interest, which was sustained recovery, was nearly identical as well. Although the initial plan was to report sustained recovery during 90 days of follow-up, the outcome reported was for patients followed for at least 28 days or who died within the 28-day follow-up period. The key secondary clinical outcome was death, which occurred in 9 patients in the treatment group and 5 in the placebo group. Safety events occurred with similar frequency in both populations. Specific details regarding safety outcomes were limited to the affected organ system, with the majority of events in both groups being respiratory, thoracic, or mediastinal in origin. Consistent with all other results presented for this study, the Kaplan-Meier curves for time to sustained recovery and time to hospital discharge look nearly identical for both patient groups. Given the clinical and safety outcomes as well as the results of the futility analysis, LICOV 555 met the pre-specified criteria for futility, and the study was halted indefinitely on October 26, 2020. Emergency use authorization was granted in early November for the treatment of outpatients at least 12 years in age with mild to moderate COVID-19 who are at high risk of progressing to severe disease. The different categories of patients meeting this criteria as per the EUA are outlined here. The approved dose is 700 milligrams administered intravenously one time. No dosage adjustments are required for any specific populations. The Infectious Diseases Society of America recommends against the routine use of bamlanivimab, and the National Institutes of Health guideline remarks that not enough is known about bamlanivimab to make a recommendation either for or against its use. Both guidelines cite a lack of evidence, given that the at-risk population the EUA was approved for was only a subpopulation of the published cohort. No statements by any other organizations addressing bamlanivimab are available at this time. The next antibody that I'm going to talk about is Eli Lilly's etesevimab, also known as LICOV 016. This antibody, similar to bamlanivimab, was identified from a convalescing patient. 2 antibody candidates emerged during this search with similar receptor binding domain binding blocking abilities. However, CB6, which is now LICOV 016 or etesevimab, was selected due to stronger neutralizing activity as evidenced by the lower 50% viral neutralization dose as depicted in the figure here. LICOV 016 has been studied for both prophylaxis against and treatment of COVID-19 in Rhesus macaques. In the prophylaxis model, a dose of 50 milligrams per kilogram was administered to 3 animals 1 day prior to viral inoculation. In the treatment model, 3 animals received the same dose, but administered on both day 1 and day 3 after viral inoculation. Daily throat swabs were performed through day 7 to determine viral load. Among the animals receiving prophylactic antibodies, only minimal levels of virus were detectable starting on day 1 post-infection. Treatment doses of LICOV 016 caused consistent decline in viral load starting from day 2 post-inoculation. On day 5 post-infection, 1 animal from each of the 3 groups was euthanized and necropsied with limited pathological lung damage noted in both the prophylaxed and treated animals. LICOV 016 is currently being investigated in 3 phase 2 or 3 trials in combination with bamlanivimab. Preliminary data from the combination arm of BLAZE-1 have been reported. In this arm, patients received 2,800 milligrams of LICOV 016 combined with 2,800 milligrams of bamlanivimab. Analysis of the first 112 patients showed a greater viral load change from baseline as compared to either placebo or any of the bamlanivimab monotherapy arms. Only 1 hospitalization or ED visit was noted in the combination therapy arm, and the patient was not considered to be in a high-risk group. Other secondary outcomes were similar to those observed in the bamlanivimab monotherapy groups. This combination is also being studied specifically among high-risk patients as Part C of the BLAZE-1 trial. No results of this arm have been made publicly available yet. The next monoclonal antibody therapy that I'm going to review is the combination of casirivimab and imdevimab, also referred to as REGEN-COV2, manufactured by Regeneron. This product is a combination of 2 of the 4 antibody finalists isolated using genetically humanized mice and B cells derived from convalescent patients. All 4 monoclonal antibody finalists had potent neutralizing activities, as shown in the figure on the left side of the slide. In addition to testing the neutralization capabilities of the 4 individual antibodies, combinations of 2 antibodies were examined. However, no improvement in neutralization activity was demonstrated with either combination. The components or individual products highlighted in the red boxes represent the compounds ultimately included in the final Regeneron product. The ability of each monoclonal antibody to carry out effector functions was studied as well. REGEN-10987, the red line in the figures on the right, was the most effective at mediating cytotoxicity of the SARS-CoV-2 virus at around 20%. The ability to mediate antibody-dependent phagocytosis was also examined for each of the monoclonal antibody finalists, with REGEN-10989, 87, and 33 all displaying similar induction potential of around 55%, and REGEN-10934 about 15 percentage points lower. The rate of virus mutation under selection pressure from the 4 previously discussed individual antibodies, as well as 3 different antibody combinations, was investigated. Virus grown in the presence of the combination of REGEN-10987 and 33 did not result in the growth of any escape mutants. This is thought to be because there is no overlap in the binding locations of each of the 2 individual agents within the receptor binding domain, and thus there is a lower probability of simultaneous viral mutation occurring at 2 distinct genetic sites. Although the combination of REGEN-10989 and 87 appears to block growth of escape mutants as well, the 2 antibodies in this cocktail do partially compete for binding sites, which is less ideal. The results of these 2 in vitro studies placed the combination of REGEN-10987 and 33 as the leading contender selected for clinical trials in both animal and human studies. Animal models using REGEN-COV2 for prophylaxis and treatment have been performed with Rhesus macaques and golden hamsters. In the macaque model, 2 studies were performed using 2 different viral inocula. The first study administered a 50 mg per kilogram antibody dose to 6 animals and placebo to 6 animals, followed by administration of a viral inoculum of 1 × 10 to the 5th plaque-forming units 3 days later. Nasopharyngeal swabs and BAL fluid were collected on specified days for viral load assessment. The second study utilized a 10-fold higher viral inoculum and compared the activities of 2 different antibody doses, a 0.3 mg per kg and a 50 mg per kg dose to placebo in 12 animals, 4 in each group. In this study, nasopharyngeal and oral swabs were collected for viral load assessment. In the treatment study, 8 animals received 1 of 2 different doses, either 25 mg per kg or 150 mg per kg of the antibody combination 1 day after being inoculated with the SARS-CoV-2 virus. Nasopharyngeal and oral swabs were collected. Similar to the studies previously discussed, changes in both genomic RNA and subgenomic RNA were observed. Findings from the prophylaxis models are described on the left side of the slide. Both prophylaxis models showed more rapid clearance of genomic RNA among animals receiving the 50 mg per kilogram dose as compared to placebo. Most significantly, the subgenomic RNA was almost completely ablated in both groups of animals receiving the 50 mg per kg dose, signaling near complete blockage of viral infection even among animals administered a higher viral inoculum, as depicted in the figure on the left. The lower 0.3 mg per kilogram dose did not appear to offer any protection against viral infection. In the treatment model, both antibody doses displayed similar rates of viral clearance and efficacy. Importantly, higher viral titers were noted on day 1 for the group receiving the 150 mg per kilogram dose, which may have potentially masked any enhanced antiviral activity. Lastly, pathological lung findings of SARS-CoV-2 were documented less frequently among animals in both the prophylaxis and treatment groups, and, when present, was less extensive than in animals who received placebo. Antibody activity was also studied in golden hamsters, where SARS-CoV-2 infection manifests much more severely than in the macaques. Both the prophylaxis and treatment models studied the effects of 3 different doses against a viral inoculum of 2.3 times 10 to the 4th plaque-forming units. Infection with SARS-CoV-2 in hamsters results in rapid weight loss and high viral load in the lungs. As such, animals were assessed for weight loss over the 7 days post-infection. Additionally, in the prophylaxis model, viral load in the lungs at day 7 was examined. Protection from weight loss was observed across all antibody regimens in the prophylaxis model and among the 2 highest doses in the treatment model. Both genomic and subgenomic RNA were decreased from baseline in most of the animals receiving prophylactic antibodies. Importantly, even in animals whose viral loads showed less of a response to prophylactic administration of antibodies, protection from weight loss was still demonstrated. Multiple trials assessing the clinical efficacy of the Regeneron product are ongoing, with ambulatory treatment data available. Of note, the Phase 3 trial listed here in the 4th row initially enrolled inpatients in 4 different cohorts depending on oxygen needs: patients not requiring oxygen, patients on low-flow oxygen, patients on high-flow oxygen, and patients on mechanical ventilation. A press release from Regeneron on October 30th stated that an independent data monitoring committee recommended pausing further enrollment of patients requiring high-flow or mechanical ventilation pending collection and analysis of further data on patients currently enrolled due to a potential safety signal and an unfavorable risk-benefit profile at that time. Notably, however, the recovery trial has made no changes in their enrollment criteria to date and continues to enroll patients with all types of supplemental oxygen requirements. The first results from the Regeneron outpatient treatment trial have been published. This publication describes results from a seamless Phase 1, 2, and 3 trial examining the efficacy and safety of 2 different doses of the combination of casirivimab and imdevimab compared to placebo in 275 non-hospitalized patients with COVID-19. Enrolled patients had to be 7 days or fewer from symptom onset with a positive COVID-19 test within 72 hours of randomization. Importantly, anti-SARS-CoV-2 antibody screening was performed in all patients upon entrance to the study. However, serologic status did not affect randomization. The pre-specified virologic outcome was viral load change from baseline through day 7 among patients who were serum antibody negative at baseline. The clinical outcome evaluated was the proportion of patients with at least 1 medically attended visit, defined as any office visit, telemedicine visit, urgent care visit, ER visit, or hospitalization in the overall study population, as well as in the seronegative subgroup. Demographics of all randomized patients are described here. There appears to be a good representation of traditionally underrepresented populations for clinical trials, with over half of the population being Hispanic or Black and over 1/3 being obese. Over half of all patients had at least 1 risk factor for hospitalization, which was defined as age above 50, obesity, cardiovascular disease, including hypertension, a number of chronic lung, metabolic, kidney, or liver diseases, and immunocompromised, meaning either immunosuppression or receipt of immunosuppressants. Before I get into the results, it is important to point out the differences in baseline viral loads between seronegative patients, those who did not mount an antibody response, and seropositive patients. You can see here that there is an incredibly large difference in the median baseline viral loads between the 2 serogroups. There was also a smaller group of patients who had an unknown serology status at baseline, meaning their serology status was either unable to be evaluated or they had borderline results. These patients had baseline viral loads somewhere between those seen in the seronegative and seropositive patients. Overall, treatment in both antibody groups showed numerically greater viral load reduction compared to placebo. However, the decreases appear to be driven by the changes in the seronegative population. In the pre-specified key virologic endpoint patient population of those who were seronegative at baseline, viral load decreases were between 0.5 and 0.6 log 10 copies per milliliter greater compared to placebo in the lower and higher dose treatment groups, respectively. These figures show the median % reduction in viral load compared to placebo at day 7. you can see that patients with the highest baseline viral loads achieved the greatest benefit from antibody therapy. Patients with baseline viral loads of at least 10 to the 6th experienced 95% or greater decreases in viral load compared to placebo-treated patients by day 7. In terms of medically attended visits, recall that these could range anywhere from a telemedicine visit to a hospitalization. In total, there were 12 documented visits between the treatment groups and placebo group, with 10 of these 12 occurring in patients who were seronegative at baseline. Frequency of medically attended visits was 50% lower among patients who received antibody therapy compared to those receiving placebo. Specific details regarding visit type was not provided. No differences in serious adverse events were reported between the treatment and placebo groups. In addition, events of special interest, including infusion-related reactions or hypersensitivity reactions that were grade 2 or higher, occurred infrequently across all treatment groups. While the published study just discussed provides information regarding the first 275 patients enrolled in this trial, the EUA fact sheet includes select information for a larger dataset of 665 patients. Patients in the combined treatment groups experienced a mean change in viral load from baseline through day 7 that was 0.36 log copies per milliliter greater than patients receiving placebo. This was nearly identical to the 0.41 log copies per milliliter difference reported in the published results. The figure on the right is from the EUA fact sheet and shows the changes in viral load for both antibody dose groups, with the change curve nearly identical for both doses. The EUA fact sheet only reports hospitalization and ER visit data with no mention of outpatient physician office or telemedicine visits. Rates of hospitalization or ER visit within 28 days occurred in 4% of the overall population receiving placebo and 2% of the population receiving antibody therapy. Among high-risk patients, however, a greater proportion of placebo-treated patients had a hospitalization or ER visit, while the proportion of treated patients meeting this outcome was similar to that of the overall population. Time to symptom improvement doesn't appear to be affected by receipt of antibody therapy. A press release by Regeneron in late December described preliminary results from their phase 3 trial of the casirivimab-imdevimab combination in hospitalized patients on low-flow oxygen, defined as nasal cannula, simple face mask, or other similar device. At this time, all that is reported is that the combination antibody product passed the futility analysis by showing a decrease in the risk of death or need for mechanical ventilation among seronegative patients. The time-weighted average daily viral load changes through days 7 and 11, as well as the change on day 5 compared to placebo, were reported. Overall safety events were noted to be similar among patients receiving treatment drug and placebo. This trial is also studying the effect of the combination antibody product in hospitalized patients with no supplemental oxygen requirements. However, no preliminary results in that patient population have been made available yet. Emergency use authorization was granted in late November for casirivimab and imdevimab for the same population as previously discussed with bamlanivimab. There is no information available currently describing the overlap between the EUA-approved patient population and those who were seronegative or had high viral loads at baseline. Given there is no current testing readily available to identify the patients who are seronegative or have high viral loads, it remains unknown if the EUA population is truly the appropriate surrogate marker for patients that would benefit most from receipt of Regeneron therapy. Given the similar outcomes with both studied doses, the EUA-approved dose is the lower of the two, 2,400 milligrams. There are no dose adjustments recommended for any specific populations, and administration requirements are identical to those of bamlanivimab. The NIH COVID-19 treatment guideline provides the same recommendation for the Regeneron antibody combination that it provides for bamlanivimab, which is that at this time there are insufficient data to recommend either for or against the use of this product. To date, the IDSA guidelines have not addressed this therapy. Multiple other monoclonal antibodies are being investigated, with the ones listed here the furthest along in clinical trials. In summary, both bamlanivimab and the Regeneron combo antibody may provide some benefit to outpatients with mild to moderate disease. However, we are awaiting further studies for both agents in order to determine the specific at-risk patient populations who will benefit most. The data for the Regeneron product appear promising in seronegative patients, but without the routine use of baseline viral load testing or antibody screening, implementation in the correct patient population will remain a challenge. We look forward to more data being published to help direct utilization of these products to the patient populations that will benefit most. Thank you to SIDP for the opportunity to present this information, and please feel free to contact me with any questions regarding any of the information discussed here.